lecture, we will review the case of Tina T, who will do a behavioral assessment in a case of domestic violence. Tina T was a 36-year-old college graduate who worked as a computer sales representative. She had a 5-year history of domestic violence towards her husband and her 10-year-old daughter. Tina contacted a behavior therapist when her husband threatened to move to another city with their daughter if she did not seek help. In the initial interview, Tina admitted that she had a serious problem, which she described as, quote-unquote, uncontrollable fits of anger. The therapist asked Tina a series of questions to evaluate the nature of her problem and its maintaining conditions. The questions included: when you have an uncontrollable fit of anger, what do you do? How do you feel? What are you thinking? What bodily reactions do you experience? What seems to precipitate your anger fits? Are they associated with something your husband or daughter says or do? Are there any situations that make you more prone to have a fit? Where do your fits usually occur? Who is there at the time? At what time of day and on which days of the week do they occur? What feelings and thoughts do you have right before an anger fit? What happens after your anger fits? How do your husband and daughter react to your fits? What do they do and say? How long do their reactions last? What do you do after your fits? How do you feel and what thoughts run through your mind afterwards? What strategies have you used to deal with your problem and how successful have they been? In the initial interview, Tina told the therapist that her anger fits initially involved yelling and cursing, then throwing objects at her daughter and husband, and finally beating him with her fist and household objects. She became angry whenever she was frustrated about a situation she believed she could not handle, such as unreasonable demands from others. Her fits most often occurred shortly after returning home from work. A fit, which rarely lasts more than 5 minutes, would gradually subside and become less violent as she vented her anger. At that point, she would start to cry and beg for her family's forgiveness, which usually was forthcoming. Other assessment procedures were instituted to confirm the accuracy of the information Tina gave in the interview and to provide additional data. Tina filled out the NAI that assesses anger reactions in a wide array of situations. The inventory contains descriptions of 80 situations, and clients rate the degree of anger they would expect if the situation actually occurred. Tina started an anger diary in which she described each instance when she became angry. She also rated the intensity of her anger using a scale rating from no anger to rage. She noted how she reacted to her own anger, including overt and covert behaviors. and she described the consequences of her reactions. The anger diary provided the therapist with information about the situations that elicited Tina's anger, the ways in which she typically responded, and the consequences of her anger. It also helped Tina become more aware of her anger and her reactions to it. Tina continued to use the anger diary during therapy as an ongoing measure of her progress. To directly observe Tina's behaviors, the therapist visited Tina's home on 3 consecutive Tuesdays shortly after she had arrived home from work. Besides assessing Tina's aggressive acts towards her daughter and husband, for example, yelling and hitting, the therapist recorded positive behaviors such as praising and physical affection. Using a modified Patterson's coding system that listed 18 different aggressive and positive behaviors, the therapist recorded each of these behaviors that he observed Tina performed over the course of 30 minutes. In the third session, Tina and her therapist role-played several troublesome situations that the therapist learned about from her anger diary and the anger inventory. The therapist played the role of either her husband or daughter and observed Tina's reactions to provocations. Tina's heart rate and blood pressure were monitored during the role-playing and compared with baseline recordings taken when Tina was calm. On the basis of the information gathered from these assessment procedures, the therapist and Tina designed a treatment plan for 2 related behaviors: positive interactions with family members and adaptive reactions to frustration. The systematic naturalistic observations in Tina's home had revealed that Tina rarely had positive interactions with her husband and daughter. Thus, one component of Tina's therapy involved teaching her specific ways to engage positively with her family. In both the home observations and role-playing, the therapist observed that Tina reacted to provocation impulsively. Accordingly, Tina was taught strategies to help her pause and think before reacting through self-instructional training, like reminding herself to pause and think. From the interview, anger diary, and home observation, it became clear that a critical maintaining consequence of her anger and aggression was the systematic responses from her family to the remorse Tina expressed after a fit. Consequently, Tina's husband and daughter were asked to withhold sympathy when Tina indicated that she was sorry about an anger fit. Tina's anger diary provided a continuous measure of her progress over the course of the 5.5 months of therapy, and it showed a steady improvement. 2 home observations in the last weeks of therapy indicated that Tina now handled frustration and other potential provocations with restraint and often with prosocial responses. At the end of therapy, Tina again filled out the anger inventory. Both the number of different situations that evoked anger and the intensity of the anger she experienced had decreased significantly. Additionally, role-playing with concurrent physiological recording during the last therapy session showed that Tina became less aroused to potentially provocative situations and that she responded in more socially appropriate ways than she had in the past. 2 follow-up telephone interviews with Tina, 6 and 12 months after treatment, indicated that her anger and violence were no longer problematic for her or her family. To summarize the highlights, the essentials of behavior assessment, just remember, assessment procedures supplied information to clarify the problem, design target behaviors, identify maintaining conditions, and then design a treatment plan and monitor the client's progress. Employing a multi-method or multimodal approach provides a comprehensive assessment. Finally, treatment and assessment are always closely linked.